Greetings my dear friend, my name is Maxim and welcome to my channel, and today we are going to be discussing glucose transport across the membranes. This is part 1 of the sequence of lectures regarding this topic, and today we will be focusing primarily on sodium glucose linked transporters, and I will briefly mention about sodium independent transport. Well, without further ado, let's enjoy the lecture and dive into it. So let's start with a simple definition, shall we? Sodium-dependent glucose cotransporters, SGLT1 and 2 respectively, are a family of glucose transporter found in the intestinal mucosa enterocytes of the small intestine, SGLT1, and the proximal tubule of the nephron. And now I am drawing the gastrointestinal tract. Of course, this is anatomically incorrect diagram, but for our understanding purposes only. And this is my representation of enterocyte. There will be 2 of them, with its luminal or apical surface of the membrane, as well as basolateral surface of the membrane. Here we go, another enterocyte, and between the 2 there is a tight junction. Because of the tight junction, proteins from the basolateral side of the membrane cannot end up into apical side of the membrane, and vice versa. On the basolateral surface of our enterocyte we have an awesome protein which is called sodium-potassium pump. Basically, what this protein is doing is throwing 3 molecules of sodium outside the cell, keeping the overall sodium concentration inside our enterocyte low. And it's also responsible for pushing 2 molecules of potassium inside the enterocyte. Just keep in mind that cells are bags of potassium, which means during a severe trauma, burns, or even tumor lysis syndrome, we can end up with hyperkalemia, which actually can kill a patient. Outside the cell, the concentration of sodium is somewhere around 140 milliequivalents per liter, which is a relatively high number. And this is why our sodium-potassium pump has to push 3 molecules of sodium against the concentration gradient, or you can think about it like pushing something uphill, which is a hard task. That's why this protein is a primary active transporter with utilization of ATP molecule. And as far as our SGLT1 goes, it is basically a secondary active transporter. How come? During its work, sodium actually transported inside the cell via facilitated diffusion, because as we discussed earlier, the overall concentration of sodium inside our cell is low, so there is no issue. But with glucose is another story. Glucose concentration inside the cell is relatively high, and that's why we have to push glucose against its concentration gradient. But SGLT1 does not utilize ATP molecules directly. This job is done by our beloved sodium-potassium pump. How can we actually prove that SGLT1 is secondary active transporter? Well, let me tell you. I'm going to use a molecule called obane. This is actually a toxic substance which can inhibit sodium-potassium pump. And when it's done, sodium cannot be transferred outside the cell anymore, so it accumulates inside our enterocyte. And furthermore, our SGLT1 cannot transfer sodium and glucose because facilitated diffusion on the sodium side fails. So no glucose and no sodium. Or in other words, Obeying directly inhibits sodium-potassium pump or primary active transporter, but indirectly it also inhibits sodium-glucose linked transporter. Another interesting fact that I must mention about SGLT1 is that it has two domains, one for sodium and another one for glucose or galactose, which means if there is a lot of glucose and galactose inside the gut lumen, they will actually compete for the spot. And what about fructose, you may ask? Well, fructose is rapidly metabolized by liver, thus concentration of fructose in the blood is low. And that's why we can use facilitated diffusion in order to transfer fructose from our lumen inside the enterocyte. We have to use glucose transporter type 5 to do this job. It is a weird name, but it is what it is. Glucose transporters were named accordingly to their sequence of discovery, and just remember that for fructose we actually use GLUT5. And the fate of our heroes, glucose, galactose and fructose, becomes very easy when we have already transferred them inside our enterocyte. We only need one protein, which named glucose transporter type 2, which is a bidirectional transporter, but we will discuss this one in great details in a further lecture. But for now, glucose transporters type 2 are located on basolateral surface of our enterocyte and conduct our glucosis to the bloodstream via facilitated diffusion, of course. And now it's nephron's turn. Well, glucose and sodium are freely filtered, and we have to make sure that no glucose will end up into urine. That's why we have to divide proximal convoluted tubules into segments 1, 2 and 3. Why we do this? Because we have a new hero, sodium glucose link transporter type 2, which is responsible for almost 90% reabsorption of all filtered glucose, which is quite impressive. Both SGLT2 and glucose transporter type 2 have low affinity but high Km, which means they work best when glucose concentration is high. And by the way, if you would like to know more about pharmacodynamics and pharmacokinetics, I have already uploaded this lecture on my channel, so just use this link if you want to. So let's return to our lecture. The rest of the filtered glucose is reabsorbed in segment number 3 via SGLT1, which is high affinity and low Km protein. The same is true regarding glucose transporter type 1, which means those proteins work best when glucose concentration is low. Additionally, weight-losing oral antidiabetic drugs such as gliflozins work on SGLT type 2, but not on SGLT type 1. That's why hypoglycemic side effect is rare. Well, let's make a conclusion. Glucose transporters can be divided into two major categories. First one is sodium-dependent transporters, as we were discussing in great details during today's lecture. And the other category is sodium-independent, which is going to be our focus during next lectures. Some interesting facts. Sodium glucose linked transporters are sodium dependent, are examples of symporters, and are primarily located inside gastrointestinal tract and kidneys. And those are examples of secondary active transporters. Whereas GLUTs are sodium independent, are examples of uniporters, are widely distributed all over the body, and are responsible for facilitated diffusion. We can subdivide glucose transporters into two subcategories: insulin independent and insulin dependent. For today's onwards, I want you to remember that insulin dependent is glucose transporter type 4, remember 4 for insulin. And if you want to remember in which organs we have the rest types of glucose transporters, just remember the Psyllium mnemonic BRIC LIPS, which stands for brain, RBC, intestine, cornea, kidney, liver, beta cells of islets of Langerhans, placenta and spermatozoa. Well folks, this is all what I have for you today, and thank you so much for watching this lecture regarding glucose transport across the membranes. It was part 1. I really hope that this lecture was helpful, and if so, please subscribe to my channel, leave a like and comment down at the comment section without hesitation. Well, I wish you a very lovely day and see you guys later. Goodbye.